We have been using Optiflow Thrive in the intensive care unit and also in our postoperative unit for a long time period, but now we're using it in the OR. We're using it during procedural sedation, during awake fiber optic intubations, and also down in the emergency department. During a rapid sequence intubation, you're not supposed to bag mask ventilate the patient, and since Optiflow Thrive provides a good oxygenation, without bag mask ventilation, it confers to standard practice very well. When we're using Optiflow Thrive for rapid sequence intubation, we're using 100% of oxygen all the time in order to assure that the patient is well pre- and peri-oxygenated. We'll put on a tight face mask in order to make sure that we have all the curves and the carbon dioxide curves ready after the intubation of the patient. We'll put on the nasal cannula when the patient is ready, and we'll have a flow of 30 liters per minute. If the patient is comfortable, we'll increase the flow to 40 liters per minute, and thereafter we'll do pre-oxygenation for 3 minutes. That's very important in order to clear nitrogen and also keep up the oxygenation. After induction and apnea, we'll increase the flow to 70 liters per minute. After induction of anesthesia, the patient will decrease the tonus in the upper airway, and then it's very important to do a chin lift, or you can take your laryngoscope in order to have a patent airway all the time. When we are using Optiflow Thrive in an emergency situation, it could be useful to only fill half of the water bottle in the machine in order to make it warm and humidified more rapidly. I think that all patients needing a rapid sequence intubation would be benefit for Optiflow Thrive, but those patients that we are particularly worried about are the high-risk patients, patients that are prone to desaturate, or patients that could have a difficult airway. So when you think that you will have a long airway management procedure, it could be good to have Optiflow in order to keep them oxygenated. So we've found the Optiflow Thrive very beneficial in patients with potential full stomach, since we don't have to bag mask ventilate them, and we haven't seen that there should be an increased risk of aspiration in using Optiflow Thrive during these procedures.
Louise, can you set the scene for us? How does this patient journey begin?
Thanks, Nick. So this is our patient who is going to be the focus of our discussion for the next few hours. He's been involved in a quad bike rollover accident, and that's resulted in an injury to his neck as it encountered the handlebars. He was intoxicated at the time of this accident. His demographics are, as you see on screen now. He has a weight of 105 kilograms and a height of 178 centimetres, giving a BMI of 33. So welcome to session 2.1, where we find ourselves in the pre-hospital environment. I'd like to welcome back Claire Hayes-Bradley, anaesthetist and specialist in pre-hospital and retrieval medicine. And welcome for the first time today to the panel Tim Leuenberg, a rural generalist with training in emergency medicine, anaesthesia and medical retrieval, and Robbie Simpson, a MICA paramedic and paramedic educator for Ambulance Victoria. And for our international participants today, MICA stands for Mobile Intensive Care Ambulance Paramedic. In this session, we're going to talk about the priorities and challenges of pre-hospital management of the patient with a threatened airway, and we're going to discuss some factors that impact on these pre-hospital decisions around airway management. One of the things that's a little bit unique about Australia and New Zealand is the diversity of pre-hospital care. Tim, in your rapid sequence presentation, you described the impact that distance can have on decision making, and it struck me watching your presentation that although all of our panellists work in the pre-hospital setting, your team composition really varies quite a bit. Robbie, you're a MICA paramedic. If you were responding to a threatened airway in Melbourne, Victoria, or somewhere in Victoria, who would be in your team, and what would you generally be expected to be able to do in terms of airway management?
Yeah, so we're very fortunate, I guess, in Melbourne or in Victoria, in that we have although our teams are scratch teams and we find whoever's at scene and we work with whoever that is, we train the same way and we work the same way, we work to the same guidelines, we have the same sort of thought processes and approach to scenes. So what we would typically find at a scene is two of our advanced life support paramedics in an ambulance who have a fairly decent background in pre-hospital care, including a 3-year or 4-year undergraduate degree, and they can perform a fair range of airway management. And then likely be two intensive care paramedics as well. So we have further training and education in airway management and a fair degree of pre-hospital airway management. So although we are putting together a scratch team, it's a team who have trained the same and learnt the same. So we have an advantage there over perhaps some other teams.
Thanks, Robbie. Claire, I imagine your team's probably a little different to Robbie's team. And I also imagine that you have other perhaps environmental considerations that are going to impact on airway management, both, I guess, where you're retrieving the patient from, but also the environment within your mode of transport, like these pictures that we're seeing up on screen now. How do these factors impact on your airway management decision making?
Yeah, absolutely. So we've got a picture there. It looks like a patient's just been winched into an aircraft. So we've got the bush surroundings that they were in to start with, which is a low resource area. We might have limited oxygen supplies or something as basic as that. I see you've got a fixed wing, and we do get involved with fixed wing transports together with our flight nurses. And we do the road vehicles as well. So we definitely have transport considerations. And our general rule of thumb is to try and deal with an impending airway problem before we get into that mode of transport. So whether we're out in the bush or at the roadside or in a small facility that's been caring for a patient before we retrieve them to a larger centre, very much it impacts on us. We have a critical care doctor and a critical paramedic in most instances working together, occasionally critical care doctor with a flight nurse. And as a team of two, we integrate with whatever we find locally. So Robbie mentioned linking up with paramedics on scene, and we might link up with paramedics on scene. We might be linking up with a rural GP in a small facility or a nurse-led clinic. And so we've got to work with those people, become part of their team and help them to treat the patient, which includes providing that advanced airway care.
Thanks, Claire. Look, I admit I've never been inside a fixed wing aircraft or even a helicopter trying to manage an airway in there. Can you paint us a picture? Why is it that you can't embark on such a journey and be prepared to manage the airway mid-flight?
Yeah, look, it's a good question. I imagine if you just think of getting on an airplane, and when you imagine you're sitting there, I know none of us have been on an airplane for a while, but when we used to get on planes and go on holidays, and maybe you're squashed in your seat and you put your seatbelt on tight, and then you can't quite reach the bag that's under the seat in front of you where you put your reading book, and it's a bit like that you might be seat belted in and you can't quite reach things and you can't reach your patient's also strapped in. And at the same time, you can't hear yourself over the noise of the engines and everything's vibrating slightly. It's just not conducive to good practice. And it is a million times better. Manage the patient first, then put them in the transport.
Yeah, that's fascinating. The impact of noise is something that someone who works in a relatively quiet operating room really just can't appreciate. Tim, I imagine your team might not be too dissimilar from Claire's team, but what struck me in your presentation is just the unbelievable distances sometimes that you would need to travel either to retrieve the patient or having retrieved that patient. Can you give us an idea as to what the impact of distance is on your airway management decision making?
Absolutely. So it depends which hat I've got on. When I'm a retrieval clinician, I'm working in a system with tight clinical governance, with defined roles, with sim to practice. When I'm working as a rural generalist, I'm really supporting airway incidents where the ceiling of care is relatively low. With increasing rurality in Australia, the higher chance that you're going to be attended by a volunteer ambulance officer. So whilst they can place, for example, an iGel in somebody who's comatose, they're not going to have refined skills in airway management. So as a rural generalist, I will respond to support the ambulance officers and hopefully deliver an extra level of care. But the tricky thing for us is we don't necessarily have the system around that, the tight clinical governance that the retrieval service brings. So my thing is always to think, where am I? Where do I need to be? I want to be back in my emergency department or at an aircraft or even in theatre where I can deliver expert care. So one thing we'll commonly do in rural Australia is essentially a staged primary or modified primary. We'll try and get that patient back to a rural facility with a roof, maybe access to increased airway equipment, more staff, and then deliver the care that's needed before we transfer. It can take hours for retrieval teams to arrive in remote Australia.
Yeah, that's fascinating, and the simplicity of having a roof. I love the way that you've put that. Look, I'm going to bring our experts back to our patient now, and we're going to get your input as to how we might start to think about managing this patient's airway. So our patient had a quad bike accident where he had a neck versus handlebar injury. He had no loss of consciousness and doesn't appear to have any other major injuries. He does have some stridor, although he's speaking in full sentences. He's spitting out small amounts of blood, and he can lie flat. Vitals from the pre-hospital team on arrival show oxygen saturation 98%. He has a respiratory rate of 18. He has a heart rate of 105 and a blood pressure of 160/90. This accident occurred in a country town about an hour by road from the nearest tertiary centre, and the plan is to transport this patient by road. So I'm interested if any of our panellists would plan on securing this patient's airway, would plan on intubating this patient at this time. Tim, what would you do?
It's tricky, isn't it? We're all going to agree this has got the potential to go bad. This man has blunt laryngeal trauma with the possibility of advanced airway manoeuvres potentially disrupting the larynx. So we don't really want to. But equally, things can go bad, and we don't want to be doing this at the last moment. You know what I'm going to do? I'm going to share the load. I'm going to talk to my colleagues and say, this is what I'm thinking about. Do you think it's fair? I would rather transport any patient with a definitive airway in place, which essentially means a rapid sequence induction of anaesthesia for this patient. But I'm going to talk to my colleagues in the retrieval service, and we're going to come up with a plan, share the load.
Yeah, I think that's fantastic, Tim, and something that we should all remember. Claire, I guess, one of the things that we might be thinking about is there a potential to actually cause more harm by trying to secure this patient's airway at the scene? When we weigh that up against, we are travelling via road. It is about an hour. It's not, 3 or 4 hours in a fixed wing aircraft. Do you have any additional thoughts? Do you think you might intubate the patient at this time?
I start to think of everyone I know, my colleagues, in trying to provide a general answer. And to take the first part of your question, could it possibly go wrong? What could possibly go wrong? I think everyone has that very much at the forefront of their mind when they're dealt with a blunt airway trauma. I think everyone is fully cognizant that, oh no, if I provide positive pressure ventilation from above the injury, I might cause that surgical emphysema. If I put pressure at the level of the injury, I might cause that false passage or the worst ever complete tracheal transection. And whenever I provide that definitive airway, I need my cuff to be sort of well down and below the level of the injury. And those kind of prime rules are sort of in your head as you're doing it. And I think everyone would be daunted and apprehensive at the prospect. But I like the way Tim said it is, you might not want to do it, but I think we can all logically talk ourselves around that this has to happen. And certainly within our service of Sydney HEMS and the doctor paramedic teams, we have a number of patients now who have looked similar to this, who have been safely RSI'd, and we would all advocate that is the right thing to do. The hospital may only be an hour away, but an hour can be a really long time sometimes. And nothing is going to get better by arriving at hospital. This airway has only got the potential to get worse, and nothing is going to get better about transporting them. So it's a little bit scary. Everyone knows it can go wrong, and I don't belittle those risks at all, or the mental stress of being in that situation. But this is time to take account of what you're doing, team brief, discuss those risks. But yeah, I would definitely advocate for a pre-hospital RSI on this patient.
And I guess if you were the one receiving the phone call that Tim was making to share the load, presumably you would have that discussion that you've just had with me and our audience with Tim.
Sorry, we just lost.
I think we might have just lost sound there from Claire.
Okay.
But that's okay, because I'm gonna let you off the hook there, Claire, and I'm going to ask all of our panelists. And in fact, Robbie, I might sort of see what your thoughts are here. I'm going to ask you a what if question. You know, what if our patient suddenly deteriorates? You're in the environment that we've described. We're an hour from anywhere. We're in a country setting. He suddenly deteriorates and you've got no choice but to intervene. What is your plan to secure this patient's airway?
Yeah, I mean, that's the great fear, and as Claire pointed out, this patient can only go one way, really. They may stay stable, they may be okay, but we don't know that, and we need to recognise that we're dealing with a very information-poor setting. We get the information we have, and we have to act on it, and it's never complete. So what if this patient deteriorates rapidly? I like Claire and probably Tim as well, would prefer to intubate this patient early. And in some services, not ours fortunately, that can be difficult because there are caveats around GCS as a determining factor for airway management, which is obviously not particularly useful. But we're fortunate enough not to do that. So if we've decided not to intubate this patient and they do go south, the what if is the terrifying thing. So we're looking at a laryngeal injury, and there's all those issues that come with that, disruption of the trachea and hematomas and everything else. So if we're now in a position where this patient is deteriorating rapidly, we're in a bit of a dire situation because we need to secure the airway, and it may be difficult to orally intubate them. However, with the type of injury, our sort of escape plans, our plan B, C and D, are also going to be difficult as well. So we may not be able to seat an iGel appropriately depending on what's happening in the airway. And we may not be able to perform a cric as easily as we would like to do at front of neck access due to the injury to the neck as well. So my plan would be just to follow CPGs, and our CPGs have been relatively recently updated to simplify and streamline them, and recognise that the pre-hospital setting is complex enough as it is, and we don't need lots and lots of complex options in terms of our approach to an airway management. So an RSI, a straightforward RSI with ketamine and rock would be my first approach, and I personally would go for a double setup. I would want somebody holding a scalpel with a size 6 tube and a bougie ready to go, because when we go in and have a look at that airway, we may be going into no man's land and need to take steps beyond that immediately. So that would be my primary approach, would be a simple RSI with a double setup ready to go front of neck.
Great, thanks, Robbie. Look, I'm curious to know, and Claire, perhaps you could answer this for us. If the situation arose where you had enough time to do an awake approach, is this even an option on site? Have you ever or could you do an awake technique in the pre-hospital setting?
Yeah, great question. I mean, why not put it out there? There's certainly at least one case report in the literature of a team having used a flexible optic scope to intubate pre-hospitally. So could it theoretically be done? Yes. I don't encourage anyone to get our ambuscope out in the pre-hospital environment. I actively discourage it. We put it in the inter-hospital pack for a reason, and we say, take it out when you've got a roof, to use Tim's phrase. If you don't have a roof, you don't get the A-scope. It's just currently there's issues that the technology being robust enough to survive in the pre-hospital environment, and there's the likelihood of success of that technique in that setting is so low. And when you couple that with the blood and the secretions and not being able to dry, it's just, I think, not a good idea. So I would advocate against using flexible optic scopes pre-hospitally.
Great, thanks, Claire. This morning we talked a lot about, I guess, team training and how we might, together prepare for managing a threatened airway. In the hypothetical deterioration I've just given you, prior to securing the airway, let's say according to Robbie's technique, Tim, how would you brief your team? So immediately prior to embarking on the RSI double setup, how would your team brief go?
Yeah, so it's particularly challenging in the rural environments working with volunteers, mindful that these are people whose normal job is farmer, shopkeeper, etc. So then they're clinicians, but the terminology is unfamiliar and they are very much occasionalists. So there's a lot of focus on the rural generalist here as the expert on scene. So how am I going to brief? Well, role allocation, but mindful there are some things that I will be doing, and that will be as the airway operator, and if we do a double setup, I'll also be performing the surgical airway. One of the things I really like to hand off is timing. So somebody can count down time for us and keep a watch on the clinical observations. So we've got a good measure on SATs, etc. And also have everything prepared post intubation. So an ongoing plan for sedation, paralysis, and full physiological monitoring, including end-tidal CO2. Concomitant with that, with the brief, is also, of course, a kit dump. Now, we carry a structured airway bag that essentially has everything we need to perform.
I think we may just have lost sound there on Tim. But I think that's a good opportunity to see. I've certainly got a couple of questions, but before I come to my questions, we might just see if there are any questions coming in from the audience. Nick, has anything come through that of our audience that would like that we can ask our panelists?
Yeah, there is a question here for Claire. So as someone who works in a pre-hospital and an in-hospital setting, would your ideal approach to this patient if you encountered exactly the same patient in hospital, would your approach to securing their airway be different, your preferred approach, without the constraints of the pre-hospital environment? Hang on, we've lost sound. We're good? Oh, sorry, go, Claire.
Oh, am I back?
Yeah,
Hi.
We can hear you.
It was all us.
So I think, no, that's a good question, because we work into environments, even in those teams. We may be pre-hospital, we may be having a roof and working with someone such as Tim in a healthcare facility setting. I think when it comes to keeping things simple, and when things get stressful, it's really nice to keep things simple. And I would fully support anyone using an RSI technique. They might want to discuss whether they're going to use a bougie or whether they think that might worsen a false passage if it's a grade 1 view. They might want to do pros and cons on ventilating before intubating for fear of causing subcutaneous emphysema. You know, there's a few nuances maybe to that RSI, things that people may choose to do or not do. Support that keep it simple approach. That said, I can imagine a scenario where if we were in a clinical situation where we had the bandwidth to think a little bit wider, it's not impossible to think that within our teams that some of our teams might choose to do a double setup RSI. So still looking at an RSI, still using Tim and Robbie's sort of blueprint of how we're going to manage this, but potentially using the video laryngoscope to look above the cords and then using the ambuscope to look below the cords to ensure that we're getting that cuff below the injury. And I don't think that would be outside the realms of possibility for us as a retrieval team. I think some of my colleagues might choose to go that way, but I would fully support keeping it simple as well.
Thanks, Claire. We've got another question there, Jeffrey Menzies. Team training. My briefing was once based on we'll do it the same way today as we practiced yesterday. Do we allocate the time and resources to having this level of practice? Lawyers, I'll let you allocate that.
Robbie, I'm really interested to hear your thoughts on this one.
It's an interesting question. I think there's probably two parts to the same kind of question. So there's the day-to-day. Do we have time at a station or a hospital or wherever to do some training? And the answer, particularly at the moment in COVID Australia, is no. We are simply inundated with work and do not have downtime much as we would like to train. So it is very difficult. And this is particularly difficult in some of the rural settings who have a low volume of work anyway. So there's a whole lot of questioning there around governance and who do we allow to intubate and or to RSI, probably more pertinently. And that probably comes to the other part of the question of who should be intubating pre-hospital anyway. I'm not going to get into a turf war here because that's not what it's about. However, to have a successful pre-hospital intubation, pre-hospital RSI program does require a large commitment of time and energy and money from training, oversight, QA and QI, audit, all those sorts of things. It's an intensive program for an organisation. And if an organisation is not in a position to commit the resources for that training and taking the time and making sure everyone does get updated and everything else, then, if you can't do it well, you probably shouldn't be doing it at all. It's risky enough as it is, regardless of who's doing it, and the resources need to be committed to do it well.
That's really a question of commitment of institutions, isn't it? We talk about making time for this. It's interesting. When COVID came along, suddenly everyone was motivated and there was all this time available to do interdisciplinary training because people were scared and it was recognised to be a priority. But in general, it hasn't been. I think it's one of those things we can take away from COVID. I think we've got time for one more question from the audience. Louise, I'll let you throw this out to who it belongs with. Are LMAs used in the pre-hospital setting, and how often and for what indications?
Nick, whoever that was read my mind because I was going to ask exactly the same thing. And I think, Tim, you mentioned an iGel somewhere along the road there. So what are your thoughts on the use of, perhaps not in this patient, because in this patient we are fairly certain that the problem is, we think the problem may well be below the glottis, but generally are LMAs in common use in the pre-hospital setting?
And the short answer there is absolutely, not for this case. But I think it never ceases to amaze me that I work in environments where farmers and shopkeepers acting as volunteer ambulance officers can reliably and safely place an iGel. And I think that's just absolutely fantastic. It really has democratized the airway. Concomitant with that, though, is the training. And I'm going to hark back to the previous question. As a rural GP anaesthetist, I'm very lucky in that I have a lot of control in my theatre. So I can use that as a training environment for these volunteer ambulance personnel so that they can come to theatre, they can get good practical experience with managing different airways, placing iGels, doing effective chin lift jaw thrust. And that's really the skills that are going to keep patients alive in the pre-hospital environment, particularly out in rural where treatment ceilings are low and frequency is relatively low as well. So I'm really self-interested. When I have my rollover, I want these guys to be able to give me a good jaw thrust and put an iGel in for me.
We'll squeak in one more question. Ian Summers, our own Twitter moderator, he's had a bit of a conniption on the keyboard there. I think he's meant to write neck rescue, but has sort of written some weird acronym. Would neck rescue be any more difficult than usual with this trauma mechanism? So if everything went wrong and you had to rescue with neck rescue, any tips, anything you do differently, any concerns about performing neck rescue with this trauma mechanism?
Tim, you mentioned, I was going to say, why don't you go ahead, Claire, and then Tim, you mentioned your bomb-proof method for a surgical airway in your presentation. Perhaps if Claire tells us what she could do, and then you can tell us whether that matches your bomb-proof method, that'd be really fascinating for me to hear.
That's it, yeah. I'll tell you what I do, and then Tim will tell you how to do it properly. I think there's real concern for the level of the injury, and I think general plan for a surgical airway is we want to go below the level of the injury, not only with the cuff of our tube, but probably with our incision as well. So we're no longer really talking about a cricothyrotomy, because that cricothyroid membrane is going to be probably higher up the airway than we're going. So if you, on that photograph, we had that great red line, you probably want to go below the red line. So you're into the more scary tiger country where it bleeds a lot and is a bit more difficult to feel. But yeah, we're going low, below the injury.
Okay, great discussion. Louise, unfortunately, I think that's all we've got time for.
No worries. Well, look, thanks. I'd really like to thank our panel members for a fabulous discussion. Certainly hearing about the challenges of the pre-hospital setting makes me very glad for the relative comfort of my operating suite and the orderly settings that I work in. Here's what I've learned. I've learned that team composition of pre-hospital teams varies very significantly. I've learned that there are significant differences, not only in the team composition, but in processes and situational factors, even within Australia and New Zealand. And all of that feeds into decision-making about when and where to intervene in a patient with airway compromise. I've heard that there's a need to think beyond patient factors and consider team and situational factors that are going to influence the decision whether or not to intubate the patient. I've heard that despite the diversity, there really is fantastic communication and a common sort of shared mental model that's supplemented by what sounds to be excellent team training. And it certainly sounds like our expert panel of pre-hospital clinicians adhere to the keep it simple approach when planning timing and type of intervention to secure the airway. So this brings us back to our patient. The patient has now been loaded into an ambulance as is, and he, in about 60 minutes time, he's going to arrive in the emergency department where we're going to continue his journey.